All, this is Dr. Mobeen Sayed from DrBeen.com. Welcome to one more show. My favorite day today, the open forum, our one-on-one, our heart-to-heart. So hopefully you are all keeping safe and healthy. Let us start our discussions. I'm gonna, of course, today interact with the cool beans as well. So Margaret, welcome. Absolutely. Yes, this is my favorite format. 1x2, welcome to the talk. So let's start. The discussion today, of course, we are going to start with the Twitter where the questions have been. And if you wanted to follow me on Twitter, the handle is on the screen right now. And this is at DrBeen_medical. So please follow if you like, and then if you can put your questions there, that is great as well. Was waiting, welcome. Joanne, welcome from Oregon. Silver Pie, welcome salam. Jamie, good evening to you as well. AS, I watch your videos every week. Great job, sir. You're welcome. Thank you. Cindy, happy Friday back to you as well. DJS, Wisconsin, welcome. All right, so let's start. So first of all, the Cool Bean updates. Good news that majority of the Cool Beans that I had been working with who had COVID in the last few days, they have all recovered. One of the patient was serious. That was a 70 years old. I was really worried about them. And since we started, and he was already taking remdesivir, dexamethasone, enoxaparin, and all the other cocktails. And I started him on vitamin D, zinc, quercetin. They didn't have quercetin, so onions and apples. And with that, the most important thing was ivermectin. And the next day, so till that time, for 5 days, the person's labs were going downwards. The intensity was increasing. The oxygen saturation was dropping. And his own son is a doctor, and he was quite disappointed, and he was quite scared. And the day ivermectin started, the second day the patient started recovering. And now today they reported and they said, all good, nothing more to report. He is actually walking about, he's happy, and he's all good. So that is a good news. There is one more Cool Bean. I came in a little late for her. She is in a corona ward at this time. Her oxygen saturation had dropped a lot. She's on 15-liter oxygen at this time in the ward. But since the ivermectin start, her oxygen that was about, with oxygen supply, her saturation that was about 88, 89 has gone back to 93-ish. So she's still in danger. She's still at risk, but it looks like she has become stabilized and is now recovering. So this is a good news as well, but fingers crossed, we are praying for her that she recovers too. So with this, welcome to everyone. And I'll tell you that this actually takes a lot of toll working with the patients, and then seeing them going through this, and then managing them, and then hoping and praying that they recover. And so that in itself is a interesting job. Okay, so happy Diwali to you as well. Let us start the discussion now. I'm going to start the Twitter. So this is DrBeen.com, and here is the Twitter thread. And we're going to plow through this, and I'll continue to do this, that I will go to Twitter, and then I'll come back here to the live stream, and we will talk. And as you can hear, Luffy is somewhere around as well and is pitching in too. So, all right, the very first set of questions is here. Question, what is the price of ivermectin overseas? So please do me a favor. If you know the price of ivermectin in your country, please put that in your comments here. We can all agree it should be given to everyone for whom it is not contraindicated. That is correct. Thank you for being an inspiration to thousands and saver of innumerable lives. Your karma is good. Cool Bean, Richard. Thank you very much. I am actually blessed. I'm very, very blessed and touch wood that this is not jinxed. So far, at least in my patients group, no one has had any adverse outcome. So I'm blessed and I'm humble as well. I'm not bragging. I don't want to jinx it. So there is a answer here. So this was Sapien Society president, Electro Homo sapiens. So he's our president. And the answer to him was alldaychemist.com has prices. Europe has socialized medicine. So it is small copay, around $7. And I think that it is a cheap drug. So in many of the countries, it is cheap. So then continuing on, Zaid Raad says, please, Dr. Bean, can we in some way manage diarrhea associated with COVID-19? Any suggestions about GIT symptoms? Thank you. So I know, Zaid, that you are a long hauler. We have had those Twitter discussions, so I'm not revealing any of that information. One thing that I've seen in COVID-19 long haulers is that whatever is the kind of symptom they have, most of the time a steroid pulse does help them. In addition to that, of course, the symptomatic treatment which your doctor can do for diarrhea is also interesting. Now, this is also important to understand that it may be the irritable bowel syndrome that has become exaggerated because of the presence of the virus and the immune system response. So please get that checked as well with your doctor and see what needs to be done. I'm hoping that you are aware of keeping yourself hydrated and electrolytes levels correct. So it may seem that I didn't say is a remedy here. There is actually for COVID, other than those normal medications for long haulers, that is steroids or maybe fish oil or maybe melatonin or sometimes statins, there is nothing specific other than symptomatic treatment. So here is a link. All of these links are in the description. Diarrhea and other confirmed GIT symptoms of COVID-19. So again, when you go through this article, at the end of it, they would simply say the same thing, that please keep yourself hydrated and well nourished. Nam KLPK Gulf. So I would stop there. Would a president in waiting get the same drugs as the actual president? I hope so. I was hoping that when Trump had said that whatever is what he got, he would make it available to everyone, I thought that would be made available, but it is still not. So I hope that the treatment is the same for all humans or all Americans if we are in America. Okay, so then Gene Payton says, could you review the YouTube video? So Gene, when I looked at this video, this is about this private beach getaway. So maybe this is your way of advertising for them, but this was not a video that was talking about long haulers. So maybe you put the incorrect link in there. Then this one, Green Dart says, is this the final death nail for hydroxychloroquine? So this is Luffy. So here, this is interesting. This is a study from UK, and they are talking about, and I'm so sorry that Luffy is chiming in as well. So in this study, what they're talking about is the hydroxychloroquine. So what they did was they looked at, so this is a retrospective study, this is an observation study, in which what they did was they went back and saw those patients of rheumatoid arthritis and lupus who were taking hydroxychloroquine before the pandemic and during the pandemic. And they say that here is the result that they're showing. They're saying that estimated standardized cumulative COVID-19 mortality was 0.23% among and 0.22% among non-users. So 0.23% for hydroxychloroquine users and 0.22% for non-hydroxychloroquine users. I went over the data a little bit, but I need to see the data a little more to see what kind of dosage were they taking. Were they taking zinc with it? Were they taking any other vitamins and those things as well? But if we take this study on its face value, they are coming out and saying hydroxychloroquine doesn't do anything. And then Sean has a response that he does not see some of the data points that he would like to see. Continuing on, Daniel Shabir says, Dr. Mubin, if a person is recovered from COVID, can he still shed the virus? So once again, I have this is actually CDC's website, and we have talked about this in the past as well. So here is what they're saying, and I tend to agree with this. Recovered persons can actually shed the virus or continue to shed the virus through the respiratory system for how much days they are talking about? Up to 3 months. And people can shed the virus through a fecal route for about 50 days afterwards. The excuse me, the interesting thing that they are saying is, in addition, that the virus that is shed by those who have recovered, I think they have caused enough damage to the virus that most of the time it is the debris of the virus and not the virus itself. So the virus that is shed is not replication competent, meaning it is a damaged virus when they shed, but they do shed. Similarly, they say the studies have not found evidence that clinically recovered persons with persistence of viral RNA have transmitted SARS-CoV-2 to others. So to summarize the answer, yes, people can be shedding both from respiratory route and from the fecal route. However, is that infectious? Is that virus viable? I believe from the respiratory route, the virus is less viable. From fecal route, it is more viable. Honor UKB says, Dr. John Campbell was correct. So somebody had asked me, I think here, Vincent said, can we have interview with Dr. John Campbell? I have reached out to Dr. John Campbell a couple of times. He has not even responded to us. So it's not that he came out and he said, no, I don't want to join. This is the same thing. I had reached out to Medcram's doctor as well. He's done a good job. Dr. John Campbell has done a good job, and they did not respond. So that is what it is. So Honor says that Dr. John Campbell was already invited and declined, as I understand. Yeah, so he just did not respond. Trump's Chump Squad, McCabe and Comey will fight this. So I do not know what this is related to. JROD2513, considering the info on gargles. So we talked about gargles, that 3 times gargling every day with Listerine Cool Mint or betadine and so on reduce the viral load. So considering the info on gargles, is it possible COVID resides in the throat and nose during the asymptomatic period? Perhaps the adenoids and tonsils act as reservoirs for it in the early stages. The virus can actually live in our throat. Adenoids and tonsils can be part of that reservoirs as well in the adults. In the adults, these clusters of tissues can actually become reservoirs because these tissues themselves are not very active. In children, these are more active, and so they are less prone to have these tissues act as a reservoir. So to go back to your question, does the virus stay here? Yes. And can the human coronaviruses live here forever with us? And so SARS-CoV-2 live here as well, and then it can cause symptoms, and then it can go to the lower tracts as well. Tony Karalika says, let's see here. This is, I think, a long thread over here. Hypothesis by Fareed Jalali, MD. Long-haul COVID-19 may, however, be a mast cell activation syndrome that lingers after platelet recovery. So I wanted to discuss this. We have not heard of this before, or we have not discussed this before. We have talked about macrophage activation syndrome, but we have not talked about mast cell activation syndrome. So let me just very quickly explain it. And here is an important tip for the long haulers. Imagine this theory is correct. If this theory is correct, that mast cells somehow are to blame for the long hauling symptoms, then the test for that is very simple. Take an Allegra, take any antihistamine that we take for allergies, and then see if that causes an improvement. If that does cause an improvement, then that means that there is a possibility of mast cells being involved. So this is without going to the mast cell and getting those checked for the SARS-CoV-2 antibodies, we can simply test that by taking anti-allergy drugs and see what happens. Again, with your doctor's permission and with your doctor's approval. So let me just very quickly look at it here. So here is the COVID-19 hyperinflammation and post-COVID-19 illness, the long hauling, may be rooted in mast cell activation syndrome. So may be rooted. So let me very quickly just talk about what is the mast cell and how does it work. So again, mast cell is part of the immune system as well. So what happens is, imagine this is a mast cell. Mast cells are the cells that are also responsible for the allergies. So what happens is, on the mast cells, when our body makes antibodies, some of those antibodies can go and get loaded on mast cells. So let's say these two antibodies are now loaded on the mast cell. Then in the future, when this mast cell has its antibodies connect with the antigen, let's say with the SARS-CoV-2, and two side-by-side antigens have to connect together, two side-by-side antibodies have to connect with the antigen simultaneously, just like a short circuit in an electrical system. If they do that, then inside there is second messenger system, which causes the mast cell degranulation. And one part of that is histamine release. And that is what causes allergies, and that is what causes, in some cases, asthma and so on. So imagine if this is the situation. For example, SARS-CoV-2 entered a person and the immune system responded and antibodies are formed, and then these antibodies for SARS-CoV-2 got loaded on the mast cell. Then if we are exposed to the virus once more, for example, let's say the virus is sitting in our own GIT, or we are getting exposed to this virus from other people, then that antigen, that SARS-CoV-2, will then go and trigger the mast cell, and mast cells will degranulate, and they would produce histamine, which would produce its own symptoms. So this is entirely possible. I had not heard of this phenomena for SARS-CoV-2 before, so it still needs to be tested. But for those folks who are long haulers, with your doctor's permission, I am not going to be able to prescribe to you. I'm not your doctor, but with your doctor's permission, you can actually try an antihistamine, or you can try an anti-allergy, and then see if that improves your symptoms. So back here, so Kobayashi Maro, thank you very much for this one. Then there is a thread further about that, and then Tony Karalika says, thoughts on this study, covert vascular mechanism by maybe platelet viral invasion causes platelet hyperreactivity, dumping of content causing clotted and excessive serotonin release. So I have that over here. It is actually an interesting study. So what is happening is that what they're saying is that, and we know this, we have done this discussion about the platelets and the hypercoagulability state. So the videos are hypercoagulable state with COVID-19. So what we have talked about is that it is possible that the platelets can become activated and release their content plus aggregate and create thrombi, correct? So platelets can release, for example, let's say serotonin, and then that would cause serotonin syndrome. So in that case, selective serotonin reuptake inhibitors can then come in and help. So the drugs here is fluvoxamine, which is given for psychiatric needs, and they have a small study over here. In this study, what they're saying is, in this randomized trial that included 152 adults, outpatients with confirmed COVID-19 and symptoms onset within 7 days, clinical deterioration occurred in 0 patients treated with this SSRI versus 8.3% of the patients treated with placebo over 15 days, a statistically significant difference. So maybe there is something here. Maybe that this drug actually helps. Maybe this is useful to block the mast cell, platelet-related dysregulation. But once again, I haven't heard of this one before as well. So thank you very much for sharing it. I would look more deeply into this as well. But here is a study, and at least from the data that they've shown, it seems possible that there is a benefit. And Tony, I am going to actually talk about phospholipid antibodies. I was going to talk about the day when we talked about minks and masks, but that news was important to discuss as well. So because of that, I could not talk about it. So next week, we will talk about this one topic. So I'm going to stop this for a second and then go here to the live talk. So how is everyone over here? So Charles says, my doctor does not approve of any of this. Get COVID, go home, do nothing. That, Charles, and that is a problem. Again, what we are discussing here is nothing out of the norm. It is not tin hat conspiracy. This is not just some ideas that we are bouncing around. We are looking at the studies and then trying to figure out if these studies make sense. And I think doctors owe us to us at this time, that in the absence of approvals from the healthcare leaderships, at least they should try what they can to help us. I had a call from a long hauler, I believe she is here in California this morning, and she was in agony, and she herself is a doctor, and she's going through this for 5-6 months now. And I gave her some suggestions, and I felt really bad that when they talk with doctors are simply dismissing these phenomena. And that is a lack of keeping up with the information. I had the same problem with one more cool bean who was sick and was hospitalized. And I was trying to convince their doctors to give Ivermectin, and they were saying, well, this is just some quackery, and this is just some, nothing important. And whatever is approved is dexamethasone and remdesivir, and that is all we'll live with. And we shouldn't have this much of a closed mind at this time, because nobody knows what is the right answer. So then those studies that are coming in, they are giving us some ideas for what could be right. Okay, so let's see more here. Absolutely. And at least doctors at this time should be open-minded, because there is no prescribed protocol that existed from before. So 1x2 says, question, if vitamin D supplements are prophylactic, how does this work? So I've done a discussion. I think now I've done many discussions, but if you search for vitamin D in my YouTube channel, the very first video that I did was, can vitamin D help fight COVID-19? In there, I have discussed in detail how vitamin D can actually help protect our respiratory barrier, and number two, cause our immune system to be balanced out, and then then allow our immune system to release the appropriate substances to kill the virus and the infected cells. You are correct. An expensive quackery at that. So they are actually doing what they are doing at this time is that there are expensive drugs, but there is a real damage, real harm that is happening to people. People are dying. So Janet says, Dr. Bean, my 80-year-old brother recovered nicely, 18 milligram daily, Q18 hours, thrice 3. Is this, Janet, are you talking about Ivermectin? Okay, so James, technically the high stomach acid in the GIT will not allow COVID-19 to survive the salt of high stomach acid. This is why we believe you cannot get COVID off of food we eat. Hopefully, Dr. Mubin can verify this or comment further. The main method of infection is known to be the nasal pharynx and airway. So James, slight modification to this statement. Let me just very quickly explain it. I had done a video, title was all about SARS-CoV-2, in which I discussed this. SARS-CoV or the coronaviruses, because they steal a lipid membrane from us, and then on top of that membrane, they have lots of proteins or glycoproteins. And I always look at these proteins like fur on an animal, just like Luffy over here has fur. So these viruses have furry substance or glycoprotein on them, which protects them from stomach acids. Because of this, coronaviruses can actually cause gastroenteritis. Other viruses, usually, who are naked viruses, that means they do not have this furry thing and the membrane around them, naked viruses do get destroyed by the stomach acids, but coronaviruses can actually survive the stomach acids, then continue on and cause the gastrointestinal diseases. So then there is a question by Shoaib Ashraf. Dr. Bean, any thoughts on the nutraceutical study from Pakistan at honey and black seed? So, Shoaib, I have been looking at the study. I've looked at it a couple of times. I just did not get a chance to present it. I will present it. I've seen it. You are welcome. So Jody says that, hi, Dr. Bean, has anyone looked into other antiparasitics or dewormers besides ivermectin? Jody, I'm not aware. Ivermectin, I'm still very, very happy that somebody in Australia actually used it and tried it and then came back and they said, yes, it works. And then people started using it. Bangladesh was the first country where it started becoming used more often, and now it is spreading. But I'm not sure about the other. So Janet, yes. So ivermectin, I am seeing like magic. This person whose 70 years old father was in a very bad state. His words were, he called me and he said that this was like a miracle that his father, who was going downwards, just bounced back within 24 hours after ivermectin. So there is a question, Beanie Menon. Question, is there any particular time to take vitamin D3 capsule? I take the dosage of 10,000 units each 5 days at early morning in empty stomach before my morning walk. I don't have any diabetes or other meds condition. Is it advised to take D3 at night for diabetes patients? So Beanie, first of all, I cannot uh, target my discussions to any one specific person. Vitamin D can be taken at any time, but normally, because it is a fat soluble vitamin, so A, D, E, and K, ADEC. We used to remember it in medical school as cat is on the ADEC, and so A, D, E, and K, these vitamins are lipid soluble or fat soluble vitamins, should be taken with some kind of a food which has some fats in it, but can be taken at any time. Adriana says discussion of early treatment continues to be dismissed and even ridiculed by media and politicians. Absolutely. This is worldwide phenomena. Some countries have it more bad and some have it less bad. And what I'm seeing is that the mature countries, the countries where the processes have been strong and rules are strong, they are actually suffering more because they're stuck in their own red tape at this time. They were not ready for the pandemic like situations. And those countries where these rules were a little less stringent, their doctors could actually do more um, experiments, if you will, and tested more drugs. They heard, okay, Mubin says ivermectin, I'm going to try it, or somebody said hydroxychloroquine, I'm going to try it, and over there the results have been better. So I forgot, 1x2, you had asked a question. I think this is your follow up. If vitamin D supplements are prophylactic, yes. So, vitamin D by prophylaxis, I would not say it stops COVID 19. But what I've seen is that everyone who kept their vitamin D levels correct in cool beans, who at least reported back to me, they had milder symptoms and they recovered fast. So I would not consider this to be a prophylaxis to prevent the disease, but I would definitely consider it to be a prophylaxis to be taken so that if we do become sick, then the intensity and severity of the disease is less. So Taylor, how do people in the US get ivermectin for at-home use? They don't. So that is a problem. There is very few doctors who are convinced to give ivermectin. Yes, so Terry, we have talked about the interferons, and I'm going to talk about that today as well. Janet says, Doctor, have you seen the very recent update by Dr. Merrick and another critical doc and a former CBS newscaster lady? I have not, but I saw an email from Dr. Paul Merrick this morning. I haven't read it yet. I would check that out and I'll see what's going on. Dr. Paul Merrick is awesome. I love him. So LB28, Dr. Bean, for a long hauler still on the ventilator, how do you assess them weaning off the ventilators? Should follow-up chest x-rays or spirometry studies repeat over time? So that is the problem. Remember my own friend's brother who stayed on ventilator for 3-4 months. It became very difficult to try to assess what is his lungs situation. Lungs were damaged severely. He eventually passed away. But during this time, it was very difficult for all of us to figure out, will the lung sustain? Can he go in rehabilitation? How long will he have to stay on the ventilators? Can we have a lung transplant, and so on? So this is a great question, but there is not a good answer available yet. Of course, chest x-ray or the other things are possible, but once again, remember, these patients are intubated, they are on ventilators, they're lying on a bed, and mobilizing them is a problem. Okay, so I'm going to go back to the, there is a question here from Doug. So my wife's MD quoted Surgisphere debunked, withdrawn study and scared my wife out ACQ, no lengthened T wave. How can I help her not to be afraid now? So I think that we all hang on to something that has made sense to us. And then we just keep finding things that keep us strong in that direction. So if she has become strong in that direction, it is difficult to then kind of try to move her from there. However, maybe ivermectin is something that she has not heard any negative news about, and she can be more convinced for ivermectin. I can tell you this, ivermectin is very, very safe. Again, other than the contraindications that I've discussed many times, and ivermectin is very effective as well. So I'm going to go back to so let me just answer one more question here from Logic, and then I'm going to go back to the Twitter. What should I do if my doctor refuses to prescribe anything for COVID? That is a general problem. Europe, UK, US, this is a problem that doctors are not convinced. They continue to say that dexamethasone and remdesivir, that is when you actually have severe symptoms, and then we'll start with that. So there is not much. I have seen some doctors here in the US some of them are my friends, some of them are not my friends, but they called me and they said, we watch your videos, we have started doing this, and we have great results. So I believe that there are still some doctors who have an open mind, but majority of them are still very, I do not know, caring, or they have a set way of working and they're not open to the studies. So So 1x2 says argue, maybe send them some videos. So I'm going to go to the Twitter side for a second as well. So Jonathan Loon says, what is the role of neutrophils in the severity of COVID-19? Whenever you discuss the innate adaptive immune system, neutrophils get a short discussion mentioned. Can you please go into more depth? Here is a paper. So number one, I have the paper over here. So thank you very much. And number two, the role of neutrophil, I would do a more detailed discussion, but just for the context here, neutrophil are also part of innate arm of the immune system. They are the first responders in our body. Their function is to immediately pick up the viruses. Remember, macrophages and dendritic cells also pick up the viruses, and then they present them to the other cells like naive T cell. Neutrophils don't do that. Neutrophils actually just pick up the viruses and kill them and throw them out, and kill them and throw them out. And the antigens they produce out in the tissue can then be taken up by the macrophages and presented to the remaining immune system. So it is possible that neutrophil can be dysregulated. and they can then cause an effect as well that can cause immune dysregulation. So I would do a more detailed discussion, but what Jonathan Loon has shown here in that study is that what he's saying is that article, that study is saying it is possible that our immune system overwhelmingly responds to the virus. In that process, it actually kills the virus, clears the virus, but ends up killing us as well. And I think that is a correct understanding. In some people, our immune system becomes dysregulated enough while trying to clear the virus out that it goes mad and it does not know when to stop, and it just attacks our body and just destroys it. So you are correct, and neutrophil may have a role as well. You are also correct that I've talked less about neutrophil. I would do another talk about it in detail. Amir Abbas says, hello, I'm a big fan. I have questions regarding ivermectin and Parkinson's. Is it safe for this kind of patient? So Amir, yes, Parkinson's. So look, the important thing, and this question is very common that I hear nowadays, that, hey, somebody had a stroke in the past, let's say 10 years ago, 20 years ago, can they take ivermectin? Or somebody has Parkinson's or dementia, and can they take ivermectin? Simple rule is the following. So let's say here is the brain tissue. And then we know that around the brain are the meninges or the protection layer. If this protective layer, if the meninges are not actively damaged, then taking ivermectin is fine. So for example, if we talk about Parkinson's or dementia, in that case, what is happening is that there is an issue inside the brain tissue, but that is not because something is coming from outside actively and causing dementia. It is possible for that to happen as well if there is meningitis or if there is other reasons. But most of the time, if we talk about Parkinson's, regular Parkinson's, that is brain tissue dysregulation within the protective layers. And if you give ivermectin, ivermectin would not do anything to damage those layers or cause any issues. But yes, if there is a patient who has an active problem with the blood-brain barrier, they should not be given ivermectin. What are the chances? So A. Lafferty says, what are the chances that ivermectin would work as a prophylaxis for someone with cystic fibrosis? So A. Lafferty, the answer is the same, that it would work for them as well. Cystic fibrosis is, of course, a different situation. Ivermectin's role is to actually get into a cell and help reduce the viral cargo going to nucleus, and then help improve the interferon release in the cells. So cystic fibrosis does not hamper the effect of ivermectin. Duke Storm Shadow says, I think he said that correct. So here is, I think, two questions. Our Cronus says, my wife is 6 months pregnant. I have seen the recent info on effects on mothers, but do we know the effect on the unborn and newly born infants? Is ivermectin okay to treat pregnant mothers, infants? Thank you. So, and Duke has responded and said no. So my answer is once again no. Ivermectin, as much as I hear people saying it is safe, you can do it, I do not believe in that. I have seen studies with these results where there is an effect. So ivermectin should not be given to pregnant women because it would cross placenta and it would go into the developing baby and cause brain damage. So it is for the baby. Similarly, it should not be given to lactating mother because it would go through the milk to the baby and hamper or cause issues with their brain tissue. So answer is no. Dr. Cole Summers. So there are two questions here. Question, since the Pfizer vaccine is an mRNA vaccine that produces only the spike protein, this is a good question, I liked it. Would there only be an antibody response instead of a combination T-cell response? Influenza vaccine does induce a T-cell response, but at a much lower level. Continued, messenger RNA vaccine is good, but would some of the other conventional vaccines types be better? So how about we do this? Let me ask the cool beans over here. Can you answer this question? Can you answer this question? That will the vaccine only trigger excuse me, antibody response, or will it trigger T cell response as well? What do you think? Okay, so cool beans are probably just having their own chat as well. So let me quickly answer this question. So Dr. Cole, here is how it works. So let's say we've given the vaccine. That vaccine has spike protein messenger RNA. That messenger RNA is picked up by some cell, which then manufactures the spike proteins, which are then presented on the part of those spike proteins are presented on the surface of the cell. This is the exact same behavior that would happen when the actual virus would come in. So the remaining immune system's behavior of going to the naive T cell, then naive T cell in the presence of interleukin 4, for example, or in the absence of interleukin 12, going to T helper 2 pathway, that going to releasing interleukin 4 and interleukin 5 and interleukin 10, and then causing the B cell to become a plasma cell and release antibodies. This would happen. Similarly, the naive T cell in the presence of interleukin 12 will go T helper 1 route, which will then release interleukin 2 and cause cytotoxic T cell to become active. And this will happen too. The only problem to understand is how much of the response is going to come from innate arm versus how much of the response, what percentage of the response is going to come from the humoral response or the antibody versus what will be the response from the cytotoxic side. And everybody responds differently. But all these three responses will be triggered by the vaccine as well. So then the second part of your question, that is the conventional vaccine better? So I'm going to give you my opinion with this qualifier that messenger RNA-based vaccines have not been used yet. So whatever I'm going to say here is more of a, from a mechanism point of view, an opinion, but not from a clinical observations point of view. Traditional vaccines have viruses in which we inject the RNAs and then inject the virus in us. I like messenger RNA vaccines better because they bring in a piece of RNA that then allows our cell to make the antigen and present it without having the whole virus in us. Or traditional vaccines have attenuated viruses, which can also be a little bit more risky compared to the messenger RNA vaccines. So in my opinion, this vaccine is actually better. What I do not know is when this would be administered and over the long period of time, what will be the results of it. Nobody knows that yet. So I'm not in a position to say deterministically that it is good or bad, but from a mechanism point of view, I like this one more than the traditional vaccines. So then there is a question from Tony Karalikas. Can you comment on baricitinib, rheumatoid arthritis drug showing promise as an antiviral? So I have that open here, the JAK mechanism. So I'm just going to very quickly talk about it, but we'll do a longer discussion about JAK-STAT mechanism separately. Using AI, artificial intelligence, we identified baricitinib as possessing antiviral and anti-cytokine efficacy. We now show a 71% mortality benefit in 83 patients with moderate to severe SARS-CoV-2 pneumonia with few drug-induced adverse events, including a large elderly cohort, median age 81 years, which is very important. A further 48 cases with mild to moderate pneumonia recovered uneventfully. So this is a very interesting drug, and I would talk about it separately as well, but seems like very decent. So here is a question from King Kong, and he's talking about quercetin and thyroid. And he's saying that does quercetin is causing hypothyroidism, and what is the alternate dose? So King Kong, couple of things here. Number one, yes, quercetin and all flavonoids can cause hypothyroidism, which will cause thyroid stimulating hormone to increase in response to try to get more thyroid hormones. Number one. Number two, what you did over here is good, that you reduce the dose to see if that would help. Number three, what I would request is that you start using some liposomal zinc as well. And so that liposomal zinc would require less quercetin or less ionophores and would help more. Then there is another related question. Stephen says, question, can zinc or quercetin affect your heart rate? So I have those articles and studies here as well. So this is 5 foods that can cause hypothyroidism. That includes quercetin. And then this is blood pressure effect of quercetin. Quercetin can actually reduce the systemic blood pressure, and quercetin can reduce heart rate. So the question here was, can zinc or quercetin affect your heart rate? Yes, it can actually reduce the heart rate, quercetin. So I'm going to switch back here to the live discussion for a second and see what's going on here. Are the cool beans still with me, or you are just having your own discussion? So Lisa says, is an mRNA safe to take either way? Yeah, so Lisa, there's a very important question, and somebody sent me a video of some doctor. It made me so mad when I watched that video. So that doctor first said, I'm the author of 6 books and I am a MD here and I'm certified there and I have done this and I've done that. And then she came up and said, I believe that messenger RNA-based vaccines are going to modify our DNA and inject things in it. And that is such a bunch of BS that I was surprised to watch that video to say, why is her license not cancelled yet? This is not the freedom of scientific talk. What she was talking was not scientific. That was a scientific person, which we assume to be scientific, talking trash and garbage and then selling it as this is correct because I am saying it. And that was so wrong of her to talk about that. This messenger RNA vaccine is not going to change the DNA. Here is why. Let me explain it. So look, what happens is, here is a cell. This is a cell. And here is the nucleus of the cell. Inside the nucleus, we have the DNA. Correct? We have the messenger RNA injected into the cell or around the cell that the cell has picked up. This messenger RNA is never going to go into the nucleus. This messenger RNA is going to be picked up by our ribosome, and it is going to be translated into a protein. That protein is the spike protein. This messenger RNA is not going to go into the cell, and it's not going to become incorporated in the DNA. RNAs don't get incorporated in the DNAs. DNA gets incorporated in the DNA. And RNA viruses, some RNA viruses or DNA viruses can inject their pieces into our DNA or other mitochondrial DNAs. But for that, they need specific enzymes to convert an RNA into a DNA or double-stranded RNA. Then, or DNA, let's just take both of them. Then somehow these have to go in, and injecting a piece of DNA into the DNA is a very difficult task. What you have to do is you have to open up, you have to cut the DNA, you have to open it up, you have to inject the new DNA in the right way. This is, for example, if you're correcting a word for the spellings, you have to go into the right place and correctly place the new letter in there. This is the same way. If you have a piece of DNA over here, that piece of DNA has to match to the sides of the DNA that you have opened up. Then you inject the new DNA in there. Then you weld them back. It is not a small task. There are so many enzymes that are needed. If this was that simple, they would have done a lot of genetic engineering already. So saying that a messenger RNA vaccine somehow is going to create DNA which would go and become part of our DNA, that is such stupid thing. So this messenger RNA is not going to go anywhere. It is just going to go to our ribosome. Ribosome is going to pick it up and make a spike protein. That spike protein is then going to be broken up and that broken pieces are going to be exposed to outside, our nucleus never comes into play in this whole game. So I hope that clarifies that. I was very angry when I saw that video. And then the person who sent it to me was a doctor as well. And she said, I'm very afraid after watching this video. And I, of course, then explained it to her. All right, so back here for more questions. So Jonathan Loon says, I wonder if it is possible that SARS-CoV-2 nucleoprotein that disrupts the nucleus could have an epigenetic effect. Maybe, Jonathan, can you elaborate a little more? So Dib Dosa says, hi, Dr. Bean, I can't figure for nasal congestion during sleep, non-allergic rhinitis. How does that fit into your T helper 1, T helper 2 diagram? Basically, so let me talk about the rhinitis in general. Eventually, what you want to do for rhinitis, for example, is, let's say this is the nose, correct? And then there are blood vessels here. And these are tiny, small blood vessels. What we have to do is that somehow we have to inflame these blood vessels, or we have to dilate these blood vessels so that they are full of more blood, and then there will be more blood pressure there, there will be more blood there, that would cause more tissue fluid, which would then result into rhinitis. That is one way. The way to amplify this, that there is enough fluid that we can now have the dripping nose, for that you need to have some sort of an immune system which is producing cytokines over here. And so, of course, as you said, one way is to have the mast cells become dysregulated or degranulated, and they would cause allergic rhinitis. And in the non-allergic rhinitis, if you have immune system based rhinitis, then immune system cytokines will be released over here. Those cytokines have an effect on the blood vessel walls, and I have discussed that in the past as well. That is the same mechanism for ARDS, for example, when the water starts accumulating in our lungs as a result of SARS-CoV-2. So that cytokines that are here would cause the blood vessels to become leaky and become dilated, and they would start oozing the fluids out, which would then become rhinitis. So back here, so there is somebody who's saying, Shizal, are you telling me that I am preaching pseudoscience? You can just generally log off if you think I am doing it. So Shizal, I don't think that you belong here. Okay, so, all right. Logic has a question. Would obesity make the messenger RNA vaccine less effective? What demographic would you think would be the most at risk for the vaccine to not be effective? So, Logic, even in obese folks, there are fat cells, and all of nucleated cells have a quality of presenting presenting the antigen on MHC1. So it does not matter if they are obese or not. We would like to go to the muscle cells and kind of release the injection there, and that can be done. So that's not going to be a bigger issue. Then you're saying who are at most risk of the vaccine not to be effective? Those folks whose immune system is not responding correctly. So if you give them the vaccine and their immune system just does not pick it up and does not respond, then the vaccine has no effect. So Deep is continuing, I believe, on the same one. So Dr. Bean, would that be the innate immune system hyperactivity? It is possible. Look, non-allergic rhinitis can be also because of the blood vessel disorders, or it can be because of the immune system hyperactivity, yes. By the way, I have blocked Shizzle. Correct. So we had the similar answer. Logic has a follow-up question. I mean, would the dose need to be higher to have the same effect? No. So the thing is this, our body's immune system does not care for obesity or not. Once the immune system is triggered, it is going to start making copy depending upon the load of the antigen and then the future exposure to the virus. So it would take care of it. No worries. The problem with obesity and other such immune issues is, in obesity, it is possible that the insulin is dysregulated. And because of that, the person's nutritional levels are low. And because of that, immune system is not functioning correctly. That is a different problem. You're very welcome. So, Nom says that why block? Let him learn. It's better to inform or ignore than censor. So I'm not trying to censor. He can still watch it. The problem is that they create so much of a noise in a healthy dialogue that it becomes very difficult to then figure out what is the question versus what are just various noisy comments. So it distracts me from trying to find the actual discussion points. So Jacob Jem George says, question, is there any truth in spacing 2 live vaccines by 4 weeks? So we know that Pfizer's vaccine needs another booster. So they give it now and then 4 weeks later again. And the benefit of that is that there is more of immune system that gets triggered. So first time when you do it, some immune system has responded. Then you give another booster dose and some more immune cells are going to respond. Plus the memory cell that was formed from the previous dose would start becoming active as well and start making antibodies too. So in some cases, vaccines do not need that, but some vaccines need it. And that is also part of the trials for them to figure out, do we need boosters or we do not need booster? Is the first dose sufficient to cause enough immune triggering to have a response? Or is the first dose sufficient, but the dose is so large that it can cause side effects, and then they reduce the dose and then give it in multiple steps? You're correct. It's just that sometimes there are just so many dispersed over the comments that I cannot read them. Good to know. Good to know. So thank you very much. Yes, I have been coughing for a few days. All right. So I also wanted to, while we are at it, I also wanted to thank Nina Kant from Twitter. She actually sent me and my wife these beautiful masks, and she had asked me if it would fit. So it does fit correctly, and I love those fish on it, and I love them. With that, she has sent this note where it said that the mask will protect against Bigfoot and then Krakens, Yetis, but not COVID-19. So she follows me on Twitter. Her name or Twitter handle is Nina Kant. If you would like, you can actually buy more masks from her as well. Shizzle can't be stopped. I can't believe you censored me. Believe it. It was not a censor. It was just you being a troll, if you are Shizzle. Okay, so continuing on. And Shizzle, if you do it again, I'll block you once more. Stratila says Luffy might eat the mask because of the fish on it. Absolutely. So once again, Nina, thank you very much. It fit very well for my wife as well. She had a separate mask. And then thank you for the mask here as well. Okay, so going back to the Twitter thread, there is a question about the pineapple and the interleukin C. So Green Parrot says, Dear Dr. Bean, many supplements combine quercetin with bromelain. However, I read that bromelain activates IL-6, which is what we want to avoid in patients with COVID-19. Is bromelain safe for prevention of treatment? So of course, anything that would trigger IL-6 can be positive or negative. If immune system is functioning as its regular thing, then IL-6 is needed for it to function. So in that case, it is fine. It is the dysregulation state when it is not fine. So let me say it this way. Let's say pineapple has something that helps with the IL-6. If somebody gets the symptoms and gets the virus, they should eat it if it helps that way. But if they are in immune dysregulation, then we are trying to block the IL-6, then they should not eat the pineapple. So that is how to look at it. The whole immune systems, all the cytokines and interferons, if the person is fighting and in a balanced way, it is fighting with the virus, with the immune system, then immune system modulators are good to give. But if the person has gone in a dysregulation state, then these are overwhelmingly badly responding. Then adding to them is not right. Then we have to suppress them. So MT had asked me to watch this video. MT, I did not do this. I would look at it at a different time. Longest recovery. Mine has been falling out for 9 months. Can't be tologen effluvium. So very quickly, here is a question from Kobayashi Maru, that is the hair loss of some COVID-19 patient a sign that the virus crossed the blood-brain barrier and entered the CNS, or is this just a possible normal complication of such an infection? So, and then the response to him is by longest recovery, and she's saying that this may not be the temporary hair loss. So let me explain the question and answer. What happens is that in some people, when they are under stress, their hair start falling out, but that is temporary and usually they recover. Now that is a skin condition and the hormonal state and the not the cytokine but hormones and epinephrine and those, it is a state of those substances. It has nothing to do with the brain. So brain of ours is locked into the skull wallet, and then it is sitting inside the meninges or the protective layers. And brain's state has nothing to do with the hair's state. Hair state is skin state. Brain has nothing to do with that. So short answer to your question, no, it is not about the brain. Long answer, that yes, it is possible that, for example, remember in the beginning, there was a nurse in France who developed COVID, and out of the scare, she committed a suicide. So it is possible that this can cause a lot of pressure on a person, and that pressure, that temporary stress, releases the stress hormones that can cause hair to fall, which would then recover later on when the person comes out of stress. Okay, so continuing. Kobayashi Maru says, there is one more. We know that active SARS-CoV-2 virus can still be found much later in the testes of boys, men that has COVID-19. Is there an update on the virus that can be present in the semen, or do males just have to worry about their future fertility? So I actually have a lecture prepared about this, that the COVID-19 present in the testes or not. But I want to make a couple of comments here before the lecture as well next week. Number one, many people have sent me evidence. Sometimes I say that this virus will not be in this tissue. And they would send me evidence that, hey, here was autopsy done on this many number of people, and they found the virus to be present in this tissue that you are saying it should not be present in. And I want to make sure that we understand the difference. Look, a person who has died of COVID, that person went into septic shock with the COVID. That means their blood vessels actually got damaged. Their blood vessels became very, very leaky, and that allowed, and the virus was rampant in their whole body. It was running around in the tissues, it was in the blood as well. It came out of the blood and went into whatever tissue it can. That can be brain, for example, if the blood brain barrier is damaged because of the cytokine storm, and that opens up the blood brain barrier, and now the virus can just simply get into the brain. It can. Similarly, virus can get into the testis as well, if we're talking about the autopsies. I do have a study that somebody had sent me where they said that in non lethal situation as well, the virus can be found in the testes, and testes are immuno privileged sites. Ideally, the viruses and pathogens cannot enter there. So I have to look at that study to see how does the virus actually enter there, and is that a serious situation, or this is just a hypothesis. So Kobayashi Maru, give me some time to look into that. But giving the examples of unfortunately dead folks who may have virus in their tissues, that is not a good example, because their whole body is under stress and their whole blood vessel system has become leaky and the virus has just gone wherever it can. Okay, so I'm gonna now come back to the live chat here. So there's a question from just another brick in the wall. Sorry for reposting my question. I've been desperate to know about this issue with these vaccines. What are the risks of developing antibody-dependent enhancement, ADE? So we have talked about this a lot before. Ideally, the ADE development has to be seen during the trial phases, and we have to see then that does it do it or not. So the idea of the trial, the phase 1, 2, and 3, and then even 4 is when the vaccine or a drug is actually in production and it is being given. We still continue to monitor it. So, but within phase 1, 2, and 3, they have to look at all of these things to come back and say, we did not observe any ADE at this dose, at this booster dose for 2 months afterwards, and everything was fine. So that means that the possibility of ADE does not go away, but the chances of ADE, the probability of ADE has to be ruled out, that it would not happen during the phase, the trials, and the dosage has to be adjusted. Or the vaccine, if it causes ADE again and again, then they would have to reject that vaccine. Yeah, so if you put the word question, it becomes easy for me to. Oh, so my camera somehow, I think it has become brighter since I did this. Let's see if I can control it to be less bright. Yeah, I think when I showed the mask, since then the camera has become dysregulated. So let's live with this one. Sorry about that. Maybe I can stop and start the camera. So give me 1 second. Stopping the camera and then starting. It didn't do anything. Oh well. Washed out DrBeen at this time. So question. So there's a question from Silver Pie. Question: flu vaccine, is it safe in asthma patients during COVID-19? Yes. So flu vaccine has a different immune system trigger, and asthma has a different problem. So ideally, the immune system enhancements should not be such that they would cause an issue, and that is what is tested during these vaccination trials. Deep, thank you very much. Barbara says we can all live with it. Perfect. Question. So letting it roll away. Question: is it possible to test seronegativity? Seronegative if one is on ivermectin coincidentally when infected with SARS-CoV-2. So all right, let me think about the question. Is it possible to test seronegative if we are on the ivermectin while we are infected? So ideally, ivermectin does provide enough protection to our cells and have them release enough interferons and prop up enough cells to not have the viral cargo go into the nucleus, that the cell can defend itself. However, that does not stop the virus from entering our cell. The That also does not stop the virus from replicating in our cells. So ideally, the seronegativity should not happen. Ivermectin should not block the production of antibodies. Sorry, I had to kind of look at the mechanism in my head to respond. You're welcome, Silver Pie. Question from Rakesh Arora. Why recovery rate is very, very high in India? Rakesh, this is one thing that I've been looking for the information for India. Many people have sent me some links as well. I haven't been able to holistically look at the data to say this is what is happening in India. It's such a big country and there is so much data. So maybe you and I should kind of partner and do some research on what is going on in India and do a lecture together. So Nina is here. So Nina, yes, your mask and your card broke my camera, but this is a beautiful mask. Thank you very much. And my wife loved her mask as well. She wore it here and then she took off with it. So Moose Lodge question, Dr. Bean, why do you think that the tests never tell the person what the cycle threshold number was? That's so important, and yet that's just say positive or negative. Yes, ideally, I would love that cycle threshold should be there. I think at this time, a standard case is that the cycle threshold has been set to 40. So you can assume it to be 40, but I would love if they actually report it and they can report at lower cycle threshold as well. So that's a good comment. AS question. What are your thoughts on vitamin A and luteolin as a prophylaxis for COVID? Luteolin was listed as a promising natural compound. So AS, my bad here that I have actually been meaning to look at vitamin A and luteolin, but luteolin, but I have not done that. And that is just my lack of time and lack of attention. I keep prioritizing the comments that Cool Beans have, but if I show you the list of possible topics, that is a long list. I would look into this. Cindy, what do you think about COVID-19 positive healthcare providers continuing to work in the hospital? Is it safe for them or other patients? Cindy, I believe you have asked me this question in the Twitter as well. So no, it is not safe. And this is not correct. To have somebody who is COVID positive, they themselves are going through a disease. They need themselves some help. They need to be isolated. They need to be separated. They need to be treated instead of asking them to be working. I actually know many cases in which the healthcare professionals have reached out to me and said, I am COVID-19 positive, but my administration is asking me to come in, wear mask and everything, and just continue to work. I think that is very wrong. So there's a question from Carlos Ortiz Monreal. Sorry for repost. I had a very brief interaction with a storekeeper who unexpectedly removed his mask when I was shopping. Are you concerned about the exposure? It depends how long you were there. It depends what was it. Normally nowadays there are glass shields between you and the shopkeepers, but possibility of exposure is there. But if they just accidentally removed it for a brief time and then put it on, I would not suspect that that would be too much of an issue. And I hope that you were wearing a mask and glasses. Whole interaction lasted less than a minute, but he was speaking loudly. I had my mask on. That took steps back to reduce distance. Very less likely, Carlos. Again, don't hold me to it. But if you are wearing a mask and you stepped back and the time period was short, then there is very less likelihood that you would have it. In the clinics, they say 15 minutes of exposure is what causes a person to get enough viral load to then become infected or become diseased. This is a good question by Veer Singh. Can we take aspirin prophylaxis in Covadira? Not necessarily. Aspirin's role is to help against the hypercoagulable state, which means immune dysregulation state. Don't need to take aspirin before. So I'm going to go back to the Twitter for a few seconds. So Kelly V says, question, hi Dr. Bean, what's your stance on COVID long haulers experiencing this virus as a vascular disease, leaky vessels, etc.? Yay or nay, treatment for such IVIG? So I have done this discussion many times before. Let me go here for a second. Look, long hauling, and I feel so sad that long hauling is happening, is one because of the tissue damage. If this is the case, if the tissue is being damaged, cardiac tissue or the vascular tissue or the respiratory tissue, then it would depend when the tissue becomes recovered. What was the damage? How much of the scarring occurred? When will the tissue actually become recovered? Till that time, long hauling state will be there. So that is one. The other possibility is that persistent virus. So if the virus is persistent in somebody, then they would continue to have this for a long time. And then the symptoms are just whatever is virus affecting. Then is a case of immune dysregulation. This is where it is possible that blood vessels can be dilated, and it is possible that there can be the fluids oozing out of the blood vessels. But normally, if we are talking about a situation where the blood vessels are all dilated and the blood or the tissue or the fluids are oozing out, that is actually a very serious situation and patient can die. That is a septic shock. So ideally, long haulers are not in the septic shock. So ideally, their blood vessels are not affected. It is more of a immune system just picking up some local tissue and kind of damaging it or releasing cytokines. If the cytokines are too many, then again septic shock can occur, but that is not the case for long haulers. That is a case for people in the ICUs. Now, your second part of the question is that what is the treatment? So Kelly, so far, of course, if you look at this diagram once more, the treatment is going to be different with the tissue damage versus different from the persistent virus versus different for the immune dysregulation. Most of my patients so far have responded to the steroids treatment for the immune dysregulation. Bert Lennon says, for someone who wants to take hydroxychloroquine prophylaxis and has a recent normal EKG, are there concerns that HCQ could trigger long QT interval and subsequent arrhythmias? P.S. Your amazing work is much appreciated. So Bert, thank you very much. And yes, this is a problem with hydroxychloroquine. It can trigger QT interval prolongation in normal healthy individuals, and I have observed that in my patients. Having said that, I think that Ivermectin is a better choice at this time than hydroxychloroquine. J.S. McClellan, given this new study that argues that the virus can persist in the intestine for months, do you believe that the methylprednisolone treatment for long haulers could potentially cause a resurgence? So very, very good question, JS. So what JS is saying is, and we know that the virus can actually stick around in the intestine for 50 days afterwards, the recovery. And remember, 2 or 3 days ago, I did a talk in which we talked about the evolution of the antibodies because the virus is possibly sitting around in the intestine and helping the B cells to continue to do affinity maturation and hypermutation of their binding sites. And they become more mature and they become more sharp in picking up the coronaviruses. So the question over here is that in such patients, if we give steroids, are we going to cause the virus to become erupted again because we have stopped the immune system? So if we go back to this this mechanism for a second for this long haulers, most of the long haulers have a problem with the immune system dysregulated than the virus persisting in the intestine. That dysregulated immune system, maybe the mast cell activation syndrome or macrophage activation syndrome or some other immune cell that has just gone mad and is continuing to work. We have to give steroids to kind of shut it down, and we don't really shut it down, but kind of suppress it for a few days and then bring it back. So even if there is some change in virus numbers, it is not going to cause a problem, because a person has actually already fought with the virus and come out of it winner. Now we are trying to correct the immune system. Couple of more questions here, and then I'll come back to the live side. How are you doing? So we are 1 hour 20 minutes into it. Let me know if it is too long, and then we'll stop. King Kong, how does one check for T cell based immunity for SARS-CoV-2? So King Kong, let me just very quickly draw that out. Remember that here is the innate arm, and then here is the T helper 2 arm, or the humoral arm. And we know that we can detect the function of the humoral arm because of the antibodies. On the other hand, the cytotoxic arm cannot be detected that easily like antibodies. So there are a couple of ways to do it, and there are no standard lab tests to detect that. I have been saying it for 4 or 5 months that we should formulate a test. One way to test that is to see the cytokines that are released by this arm. For example, interleukin 2 is released. For example, interferon gamma is released. For example, interleukin 12 is released. So these interleukin levels can tell us if there is a problem with the T helper site. Or what they do in the research labs is they culture the cells and they look at the markers on the cell and then see which kind of cell is more active, and then decide what is the actual immune response. So that kind of a test is not available. The test that can become available is more cytokine level, which are still not available. All right, so I'm gonna come back here to the live chat. And see. So there is a question by Shahida. Question: if we give Ivermectin first and then steroids, will it help long haulers better? Ivermectin's better role is when the virus is present. So I think you are alluding to this, that hey, if the virus is present in the intestine, why not we give Ivermectin and try to get that virus out, and then steroids? Yes, it is possible. Although so far when I have prescribed steroids, I have never seen the virus resurging. Because think about it for a second, our body is in overwhelming state of response. Our immune system has beaten up the virus, and beaten up with more intensity than it should have. And in that process, it has become mad. Now, even if the virus is sitting around and our immune system is out there, it's going to beat it up again. So we do not need to reduce the virus and then give the steroids. But yes, that can be done. It's not harmful what you're saying. It can be done. So Taylor says, would quercetin and zinc in one supplement help make COVID symptoms less severe? So this is the same thing at hydroxychloroquine and zinc. Ideally, yes. In theory, yes. So far, the studies, there are all kind of studies. Some studies say, yeah, it works, and others say, yes, it does not work. So in theory, Taylor, yes. So Barbara says, one of my students and his wife both had COVID-19 in April. He recovered, but she still has anosmia. I found an article. So Barbara, remember a few days ago, we talked about the myalgias and fatigue and long hauling. And in that, we talked about the lymphatic system. And we talked about the issue with the area, the nasal area, where the the lymphatic system dysregulation occurs and there is a continuous swelling there. So in this person, it is possible that that is what is going on. I would recommend to her doctor to give her a pulse of steroid and see what happens. You're welcome. You're welcome. So there is a question by RT Teetwaffle. Question: I ate pizza with onions, then went to the movies. Okay, I was wearing a mask. The smell of onions ruined the movie and the night. What can be done to prevent that? I threw the mask away. So RT, don't eat onions before wearing a mask. Good question. Happy Diwali back to you as well. Jim, thank you very much. Thank you. You're welcome. So Silver Pie question is, does flu vaccine increase the risk of COVID-19 somehow or make symptoms of COVID-19 worse due to pre-established flu vaccine associated antibody response? No. So these two antibody responses are very different. So when for example, let's say somebody has the flu vaccine, and they have the antibodies produced, and they have the memory cells sitting and sleeping for flu, and you give the vaccine for SARS-CoV-2, that is not going to do anything. There is no cross reactivity with the flu vaccine. So there is going to be no immune system extra responses. There are no memory B cells for the flu vaccine that are going to wake up and start functioning. So no issues. Okay, so I'm going to go back to the Twitter for a second. Kobayashi Maru says, I'm looking forward to the answer. So Buddha Jiva is the question. Question is, hello, Dr. Bean, can aspirin be used in early replicative phase of the virus? If so, at what dose? Here is how I do it. For the youngsters, aspirin in the early stage has no benefit because we are not expecting the immune system to become dysregulated and go in the hypercoagulable state and then need aspirin. So usually do not recommend it in the early phases. But anyone who is in advanced age, and if they were already in some kind of, let's say, cardiovascular issues, if they do not have any bleeding disorders, I ask them to start taking aspirin a little earlier so that the immune dysregulation is not kicked in. I actually try to prevent the immune dysregulation early on in those where I suspect immune dysregulation would occur. For example, I had a patient 4 or 5 days ago. She was, I believe, 60 years or so, and she started having symptoms. So for 3 or 4 days, I asked her son, who was a doctor and my student, I asked her to just do not give her any steroids or aspirins. Once she went through 3 or 4 days, and we were giving Ivermectin to her and vitamin D and other things, then at about 4th day or 5th day, I asked them to start giving her steroids and aspirin as well, because that is the time when immune dysregulation may start occurring. And so I do not wait in those folks where there is a possible risk. I do not wait for immune dysregulation to occur. I am always aggressive and try to take care of the things before they happen. So Kobayashi says, I'm looking forward to the answer. Until then, there is the opinion of another doctor. So Farid Jalali says, I refrain from recommending a cocktail, but at 200K cases per day, now COVID-19, I think it may be time to go ahead. I think folks should consider taking an aspirin 162 milligram daily, the same dose being treated by recovery trial. So again, that is a doctor's opinion, and more power to him. I do not agree with giving aspirin early on because it has no benefit. Aspirin's benefit is going to come in when the dysregulation starts occurring. So early on, Ivermectin, vitamin D, zinc, quercetin, these kind of things. And then 4 or 5 days into it, If you do not see the patient recovering well, then aspirin and then other things. So Mirror 91 says, should you add bromhexin to prophylaxis? I understood it was really promising, but after your last talk, you stopped to mention them. Is there a reason besides it? Lack of evidence, studies showing it doesn't work, expected. Sorry for the English. So Mirror, your English is fine. Yes, so I haven't yet seen bromhexin's positive effect in any study. Most of the time I'm seeing some studies say it works and others say it doesn't work. Some studies even say it exaggerates or amplifies the effect of COVID-19. Because of that, I have become hesitant about bromhexin. King Kong says, can you comment on HAT therapy for ARDS as mentioned by Dr. Merrick on one of your videos? So King Kong, I have actually done a complete video, 29 minutes, 42 seconds, hydrocortisone, ascorbic acid, thiamine, the HAT therapy itself. So I've done the whole video. So can you, and I have the link in the description. So I'm going to go back to this in a second. I'm going to come here to the live talk. How is everyone doing here? So now we are 1 hour, 31 minutes in it. So Ziaul Haq says, why aspirin 160 instead of 75? 75 is the baby aspirin, which is normally given. This is slightly double the dose. So, and that is fine. If you are suspecting that your patient is going to have dysregulation and possibly hypercoagulable state, which would be indicated by the trend for CRP and D dimers and ferritins, if that happens, then giving 150 mg is not bad. Actually, it should be even higher, but 150 is fine. So, Bikal, this is a very good question. You're saying, is there any biomarkers that we can identify in early phase of infection so that we can prevent it? There are many studies that we have talked about, which talked about genetic markers and biomarkers, which can be used to see a person's propensity to move towards dysregulated state. If you can please talk with me separately and remind me, I can probably pull some of those markers together and present them. For example, we have seen the interferon dysregulation. We have seen interleukin 12 dysregulation. We have seen interleukin 6 dysregulation. We have seen RANTES dysregulation, and so on. So there are a bunch of markers that do present an indicator that this person may be going towards more severe state. But in the absence of those, looking at D dimers, ferritin, CRP is a very good indicator as well. And on a clinical side, looking at oxygen saturation drop and how rapidly it is dropping is also a very important sign. So just a quick anecdote here, or a little my behavior. When I am managing someone, I am so aggressive that every 2 hours I'm calling them and saying, what is your oxygen levels? And if most of the patients that are brought to me are by some student or some friend doctors, and so I ask those doctors to say, did you hear the chest, and what did you hear, and where are the crepitations, and where are no. So I am very, very aggressive on the oxygen level and how fast it drops, because that is a big indicator of how the person is going to move forward. Thank you very much, Jamie. Yeah, so Denise, you have 325 milligram of aspirin daily. Very good. So there is another Silver Pie says, Dr. Bean, finally, thank you so much, Dr. Bean. Me and Luffy are really working hard at mewing and be heard, and we love so many of your cool beans. Mashallah, chill. Very good. Thank you. All are welcome, including Luffy. Luffy is actually my teacher. So he comes in and corrects me and says, you should talk this way. All right. So I'm going to continue to this side. So Kobayashi Maru says, with spike protein vaccines, there may be even more drift over time towards antibody dependent enhancement, ADE, and off target antibody generation that can enhance disease. How likely is it, in your opinion, that vaccines work well at first before they become a problematic later on? So, Kobayashi, very, very good question. And I have thought about it a lot. And here is my answer. We take flu vaccines every year, many of us do, and we do not develop ADE. For the SARS-CoV-2, my expectation looking at SARS-CoV-1 and MERS-CoV is that once we have a vaccine and once we can put this virus away from us for a couple of years, it is not going to be a problem for us anymore. And it is also going to go away like MERS-CoV and SARS-CoV-1. So because of that, I do not suspect that it would mutate in us. And if it mutates in us, that mutation is going to be more friendly towards us. The danger is what we just saw with minks. That is, the virus goes into another animal, and from there it mutates and then jumps back to us. If that happens, it's going to be a new strain, it's going to be a new structure, and the previous antibodies would not cause harm. The problem, remember, the SARS-CoV-1 happened because of the animal jump, and then the MERS-CoV happened because of the animal jump. Now this virus is worldwide. So the transmission from human to animal is increased, and then back from animal to humans will increase as well. So our bigger scare at this time is that would it continue to get into animals and then come back from there, and would that frequency increase? Previously it was 2002, then 2012, and now, and I think now the frequency, just like minks we just saw. So that is a scary part. The concerning part overall with this pandemic for me are two, other than the mutation. One is the medical leadership not being able to approve the prophylaxis and the early treatment drugs. And second is I forgot, it would come back to me. That was very concerning for me as well. Sorry, I forgot. It'll come back to me. So that is one. Second part is recommended more details about this question and about others aspect in the long, excellent lecture. So I looked at it here as well. So thank you very much. They have, to be honest, in this article, they have done a lot of discussion which seems a little more pessimistic than how the virus should behave. All right, so one more question here, then I'll come to the live side. K-pop super strong. Dr. Bean was right about the higher doses given on ACQ RCT for hospitalized patients published in JAMA. That's the Elanco protocol. That is correct. K-pop super strong. Thank you very much for this. And number two, yes, the dosage of hydroxychloroquine given in some of those trials was very bad. I want to say criminal. And I think about it many times. Sometimes I think that maybe the doctors were trying to say, maybe if we give the hydroxy in a higher dose, it would be better and it would take care of the virus faster. So maybe their intent was right. But what I keep going back to this thing is that there is a therapeutic dose established. There is a safety margin established. A doctor should know that they should not give a dose which is beyond the safety margin. So there was this question here by Kobayashi Maru. Would be great if you could publish your exact recommended. This is something that I have been trying to do it for so long, but every day I just sit down and I think about the lecture. I do my business things as well. So someday I have to take a day off to then write the protocol. The one question is about the vitamin D level, and King Kong has responded. So the level set to be normal is between 30 to 100. The level from the studies which say that people have less risk of death if this is a level that is 40 nanogram. I feel comfortable between 50 to 60. I feel 80 and above becomes a little bit more aggressive and can cause calcium level dysregulations, but 60-ish is good. So I'm going to come here to the live side. How are things here? Barbara says, hello, new people who are joining. Hi to everyone. So very good question. So Jim says, won't the supplements like D3 still work? Absolutely. They would still work. The problem is this. Let's say we use US as an example. US just went through a strain of the virus and had a huge damage, huge loss. If we get another strain which has the same capability but would not forgive those who had already become infected, then a new cycle would start. And I don't think, Jim, tell me if I'm wrong, I do not think that we in the US have learned a lesson to say we should take vitamin D's or we should take magnesium or we should take K2 with it, because it's not for people to learn that lesson. Look at my talks. I've been talking about it for 4 or 5 months, right? So there are 5 million, 6 million views, for example. That's not a very large population. So a huge swath of population is still not aware. It is the role of the medical leadership. For example, I would have expected whenever Fauci goes somewhere, he should say, hey guys, do you know that the first thing you should do is wear masks and have vitamin D? And if you do not know what dose you should take, and if you do not know that you can take it or not in high doses, go talk with your doctor. That is the kind of person who has to publicize that, or the media has to do it. Folks like me, we have too tiny a voice to make it heard at a larger scale. So you are correct that these things would help, but this awareness is not widespread. So Peyton, I have not seen it yet. I actually wanted to call him and ask him to come on once more and we talk about the Mast Plus protocol. I would look into it. Correct, Jim. And we look, most of the doctors do not talk about it. I have a channel where fine, we are doing some discussions and I'm reaching some number of people, but those who are able to reach a larger audience, CDC, FDA, WHO, Fauci's, they are the ones who should have taken up this flag and run with it. They have done a really bad job. Okay, so Anthony's question. If long haulers have developed autoantibodies, would IVIG be the solution? No. So the problem is that if they are developing autoantibodies, that means their immune system has become dysregulated and it is producing antibodies, biased B cells against some tissue of ours. So if you give intravenous immunoglobulins that can wipe out those antibodies in one go, our immune cells are going to make those antibodies again. So then we have to actually go back to our immune cells and say, guys, stop doing this, stop being mad. So that IVIG would not do. We'll have to go back to the steroids, we will have to suppress the immune system, then we have to have it bounce back and hope it does not start attacking our body again. Okay, I'm going to go to the Twitter for a second. Longest recovery. What do you suggest we do for treatment of chronic COVID patients long hauling? Long course of ivermectin? No. So ivermectin will not help in this kind of a situation. Interferon, possible. Favipiravir, possible. But I think the best is steroids. I think the antiviral course will have to be prolonged given the extent of our infection. No, so the your basic theory here is that the long hauling is because of the persistent virus. It is not necessary. It is in most cases immune dysregulation. And because of that, we have to target the immune system than the virus. Rilojero says, hello, doctor. My question would be about niacin. So I have not, Rilojero, I have not studied the niacin yet, but I've taken down as a topic to study. Dr. Dharmendra Singh says aspirin and statins for COVID. So Dr. Dharmendra, I have actually done a talk in COVID discussion about aspirin. And then I have done one more talk about statins and their role with COVID as well. So the links are in the description. Then MT says question, T helper 1, CD4 plus, interferon gamma, and CD8 T cells were produced by mice and monkeys who received the new Pfizer vaccine. Does that offer clues as to what therapeutic doctors should be focusing on? So no, really, this is the same behavior as we expect from the immune system that I talked about a little earlier as well, that you have given the vaccine created the antigen got presented on the surface, that went to the naive T cell, which would then go to T helper 2 and T helper 1 pathway. Antibodies will be produced and cytotoxic T cells will be produced. This is the same exact behavior as the actual viruses and the same therapeutic approach that we are already taking. Good question. K-pop Super Strong says, 8 months after pandemic was declared and was also a Friday the 13th, even vaccines are being distributed. I am fearing a lot of people are not going to use masks. Gather more and vaccinating the already infected may not yield a good result. We still should be careful this winter. Absolutely, I'm with you. I think that the personal responsibility is something that we have to take, as our leadership on the medical side is failing. So you are correct. Masks, social distancing, trying to be kind to others in this whole situation. I consider wearing masks and social distancing to be a kindness to others too, not only a protection for ourselves. Katia Lukin says, I want to open a can of worms. So Katia, I looked at your question. This is more about the AIDS. Maybe we should do a separate discussion for other things. I don't want to mix that topic here, but thank you for your question. Tanzo Kang says, Doc, why couldn't we take zinc and package it in a lipid particle? That is the liposomal zinc. And yes, you can take liposomal zinc, just like the messenger RNA vaccine does for the S protein. In this way, deliver zinc to the cells. Wouldn't this work on itself without? Yes. So if you have liposomal zinc, that has a tendency, it has better bioavailability because it can be picked up from the gut more easily. And if we can actually have liposomal zinc injections, and they can be directly sent in the system, then that can become available to the cells and zinc can be picked up. Cindy Glasgow says, what do you think about the hospitals requiring COVID-19 positive? So Cindy, you asked this question here in the live talk as well. I do not agree with this. And I'm seeing hospitals continuing to do this here in the US as well and in other countries too. I do not approve of this. I do not like it. Nina, thank you very much for the mask. Hu Min Bean says, question 1, would it be wise to start the Ivermectin when one has a fever and continue daily? That is what I do. I actually start as soon as I feel that somebody has COVID-19, I start them on Ivermectin and I start the family on a prophylaxis of Ivermectin. Second question is budesonide sufficient or does one need to try to acquire dexamethasone? Budesonide is mostly for the lung itself and it is inhaled, nebulized, and dexamethasone is more systemic. So if you are suspecting that the patient is going to develop immune dysregulation systematically in a systemic way, then dexamethasone. For gargling, what are the H2O mix ratios for hydrogen peroxide and betadine? I know that the alcohol is 60%. I will have to look these up in the study in which they did it. So I have talked about it, Humin, in a video, and you can see that, and you can look at the link in the description to see in the study what was the composition. I will have to look it up as well. And the last question here, Duke Storm Shadow, do you think that the Pfizer vaccine will be actually 90% effective in mass population? In your video, you mentioned how it created 3.2 times antibodies found in recovering COVID-19 patients. What are the chances that the vaccine becomes ineffective because of mutations? So 2 questions, I guess, here. One is the 90% effectivity. Pfizer still has to wait for more people to become infected and then actually come back and tell us the exact effectiveness. This was interim data of, I believe, about 92 patients. They have to wait for 164. So it is possible that by the time they reach 164, this effectivity changes. So for the time being, we cannot say that that would be the case. If the same pattern holds, then yes. The second question is that what are the chances for the vaccine to become ineffective because of the mutations? There are chances for that. And that is why most of the vaccines have more than one antigens production. Good news with the vaccine is the following. So let me explain this one part. So let's say vaccine is going to produce the spike protein. And the spike protein, let's say this is the spike protein. And remember, spike protein is a complex protein. So it has it has a lot of patterns on it. And 7 or 8 amino acids are sufficient to allow an antibody to attach with it. Right? So 7 or 8. So when this spike protein is produced, there are going to be thousands of amino acids, which will cause hundreds of antibodies to be produced. And then even if there is a mutation, so let's say there is a mutation here, the remaining system would still have enough antibody production, still enough antigenicity that we will be able to preserve ourselves. So the viral escape is more interesting when it is monoclonal antibodies. But in case of vaccines, because the vaccine is going to trigger us to produce thousands of kind of antibodies and their memory cells, we should generally be okay. So that is the side on the Twitter. We plowed through all those questions. It's 7:52, 2 hours. So a couple of more questions and then we break. So James says, question, during medical school, why is there so little focus on orthomolecular medics and the great benefits and their large safety margins, and so much attention given to prescription drugs with possible dangerous side effects? It seems there is a massive problem when patients ask their doctor and the doctor hasn't been properly taught. It seems leadership might change in the medical schools about doing no harm and how supplements. So James, 100% correct. And the reason I started this DrBeen was this, that I thought that medical students, nursing students, nurse practitioners, healthcare students generally are not given the appropriate tools to, number one, learn to learn, and number two, trust more than whatever is in the book. For example, to go after the studies, for example, try other supplements and other things as well. That was the reason that I believe that our healthcare education system need to be upgraded. And I started that process. As you can see that with COVID, you can see some of that showing in my behavior. And that is what I want for all medical education. I am a small company, so I do not have enough resources to kind of create widespread knowledge base. But that is the belief with which we have started. So you are correct. Masik says, question, but when looking at COVID that causes COVID-19, so you're talking about SARS-CoV-2 that causes COVID-19, its RNA seems to be amplified by 2 with each mutation, and there has been 18 to my current knowledge. Good question. So if I say here, SARS-CoV-2 strains, and then if I go to let me write it here, strains or mutations, next strain, if I could type correctly, next strain. You can actually hear. So if you go to nextstrain.org, Here you can actually see the mutations of SARS-CoV-2, and these are all the mutations. So it's not only about 18, there are hundreds and thousands of mutations. The important thing, and you can actually play this to see what kind of mutation was where, and where did it go, and where did it stop, and where did it start. So the concept of mutation is there, and mutation is happening. The good news are two. Number one, the mutations are not very fast as they could be. Number two, the mutations are such that the SARS-CoV is still keeping its spike protein intact because it needs to connect with us, with our ACE2 enzyme. Because of that, whatever is the mutation, because spike protein is a constant, we can still fight with this virus with the same antibodies that we had developed earlier to it. And that is the good news. So one more question, and then we break. Mary Ann says, why did recovery trial use 6 milligram of dexamethasone only? Our doctor uses 5 milligram every 6 hours. Yeah, so recovery trial was I do not know who designed it, but that was a disaster. Excellent. So this is what we have for today, with me washed out as well. And tomorrow we'll talk some more, and then day after I'll take an off. Thank you very much for being here. It is a long video, difficult to share, but still, please like, subscribe, and share. And if you wanted to support this work, there is a link in the, I do not know if it is in the description today, but there is a link in my video's description where you can actually use that to support the channel. So thank you very much, and I would see you tomorrow.